Good afternoon, everybody. Nice to be here again. I'm going to talk to you about the role that innovation can play in the reformed NHS. And to start off with, I thought we should agree some terms. There are lots of definitions of innovation, and the one that we tend to use in the Institute is doing things differently and doing different things to create a step change in performance. Innovation's a complicated journey. I'm sorry, this slide won't show very well, but what it says on the left here is the process of ideation or having a good idea. And innovation goes through a series of stages, and it's only really innovation if it's adopted. And the message about the health service in the UK is that compared to other health services in other parts of the world of a similar size, we have a really extraordinary record of being innovative in relation to ideation, new ideas. England and the UK punches well above its weight internationally in terms of our contribution internationally to innovation. But we have a very poor track record in our own country of spreading and adopting a lot of the good practice, the sorts of things that Taha has just been talking to you about, and helping them find their way from the one or two places that have invented or ideated these ideas to the places that they should be available to patients across the NHS as a whole. And I'll explain a bit more about that as we go along. Innovation's a very broad spectrum of things. It includes technological innovation in pharma, in genetics, in the use of new medical devices and ICT, but it also encompasses innovations in the way services are delivered, in policy, and indeed in the business of delivering healthcare. And one of the challenges that we have, in my view, in the landscape in the UK is that we've tended to see these different aspects of innovation as separate from one another, to have sort of special approaches to how to introduce new medication, different approaches to do with the use of new medical devices or service innovation. And the truth is many of these things interact very profoundly. So the introduction of a new medication with new opportunities to improve patient care will inevitably have a big impact on the way the service needs to be delivered, and often, and perhaps most fundamentally, on the way that the resourcing of the service needs to happen. So I think it's much more helpful if we can start to bring these different silos of innovation onto the same platform. Now, there are many examples of successful innovation in the UK, and some of them have happened very quickly and at major scale. But sometimes the way we've delivered those innovations has had unintended and difficult consequences. So this graph shows every NHS A&E department in the country. It shows their performance against how quickly people are seen in a quarter which was October to December 2003, and in a quarter which was April to June 2004. And what it shows is a dramatic move to the right, with fewer patients waiting longer over that 6-month period. We all remember that. This was when the targets were introduced, or when the requirement was placed on hospitals to deliver a maximum 4-hour wait. Now, this didn't happen just because of the target. The predecessor organisation to the NHS Institute, the Modernisation Agency, worked with a group of clinicians in a number of hospitals, developed a different approach to managing the first attendance of patients at A&E. It was called See and Treat. There was a systematic programme across the country of introducing that approach to different hospitals. It had a major impact, but as all of us know, it also had some serious clinical unintended consequences, because there's always a risk with targets that are imposed nationally in this way that people hit the target but miss the point, and that the target which seems the right thing to do from an office in Whitehall, when it gets down to every single A&E department across the country, doesn't meet every clinical circumstance. As you probably know, in that instance, the target was softened to be 100% of patients being seen within 4 hours to 98% of patients, and it's now been softened even further. But it's true that over that very short period of time, the NHS in that regard, showed a remarkable change in patient experience. This is a program that we run at the Institute. There are 620 of the things you can be admitted to hospital for, each of which has a unique price within our internal market. They're called HRGs, Healthcare Resource Groups, but 50 of them make up half of all of the activity done in hospitals. And these are the common things done in hospitals. Here are 8 examples that we began our work with: fracture neck of femur, hip replacement, knee replacement, stroke, etc. What we did was we used all the available data to find the best performing hospitals in England, and also organisations that on the basis of the data seem to be performing less well. We put together clinically led teams, led by consultants in the specialty concerned, supported by analysts, by improvement experts and by general managers, and they carried out structured visits to the high-performing organisations and the less well-performing organisations. You may be surprised to hear that quite often they were visiting the same hospital in both categories for different of these conditions, because often the experience is it's the clinical microsystem in the jargon, the group of clinicians in a particular specialty, that determine the quality of care in any particular institution. We were able to codify what the great performance looked like, and this is an example from knee replacement. The highest performing organisations had a low length of stay, had very, very high quality clinical outcomes, but they didn't actually focus on length of stay per se. They focused on optimising the mobilisation period after surgery, so that patients who had a knee replacement were up and about and being mobilised between 12 and 18 hours after surgery. Now, I mean, I've been out of clinical practice for many years. When I was in clinical practice 25 years ago, it would have been unthinkable that patients who'd had a knee replacement were being mobilised so quickly. But this is now the practice in the highest performing units in the world, but also in the UK. In order to achieve that, every aspect of healthcare for these patients in those areas which were high performing was set up to optimise this particular measure. When GPs referred the patients in the first place for a knee replacement, they'd say, we know this is a big operation, but with the high quality pain relief, with very good anaesthetic practice, don't be surprised about the fact that you'll be starting to have your physio only 12 to 18 hours after your surgery. The particular beds that were used in the high-performing units for these patients, they had bays that they used as their knee replacement bays. They did these procedures on particular days of the week at a certain point on the operating list. Their physiotherapy, rotas, their pain management, their anaesthetic practice were all designed to optimise this procedure. And yet we went to places where there were a range of different practices, frequently 4 surgeons doing knee replacements, each of whom had a different policy, and it wasn't systematically delivered. Now, we've shown, this is an example from this work in relation to caesarean section, that it's possible to take these nuggets of good practice, to work with organisations who also support one another by them working collaboratively, and over very short periods of time, in this case this is 9 months, shows substantial improvements, for example in this instance in the caesarean section rate, by organisations that haven't yet adopted this good practice being able to adopt it. And this work is now supported by changes to the way that tariff is being developed, so that the tariff can incentivise people to move towards good practice. And the evidence base on this sort of innovative approach is getting stronger all the time. This is a paper from the BMJ of earlier this year, carried out by Brian Jarman. This is a particular hospital, which showed by the implementation of accurate and careful utilisation of a range of process measures in common conditions, that they were able to demonstrate a substantial improvement in mortality within a hospital over a 1-year period. We also run from the Institute a series of programmes called the Productives. These are about putting into the hands of people who are responsible for a ward or an operating theatre or an outpatient clinic some tools which are tools borrowed from other aspects of other industries,